Good afternoon, everyone. I'm Dr. Pranita Sai, and today, thank you. I'll first like to thank AIOS and the Uttarakhand State Society for organizing this wonderful conference and giving us this opportunity. So I'll be talking about the topic OSSN chemotherapy, the way to go. As we all know that OSSN comes in different shapes and sizes. There are different morphological appearance, from diffuse plaque-like appearance, nodular, pigmented, to invasive versions. The investigation of choice always remains impression cytology, and it tells us about the nature of the cells and helps us to identify OSSN. However, with the advent of the AIOSMT and the findings that we have are described in literature, it is one of the non-invasive tools with which we can also identify OSSN. As we all know that the gold standard treatment for OSSN still remains surgery with a no-touch technique. A 3 mm mark is made around the OSSN lesion, and 1.5 to 2 mm mark is made on the limbal side on the cornea, and then with a no-touch technique a peritomy is done. 100% absolute alcohol is applied on the corneal epithelium, following which a simple and easy debridement of the corneal epithelium is done, and with the help of a crescent, a blunt dissection of the tissue or the tumor is removed. It is important that you do not reuse your instruments that you have done to dissect the tissue in the later stages of the surgery, so that you do not inadvertently do tumor seedings to the normal tissue. After the the tumor has been removed, a double freeze thaw cryo is applied on the surrounding adjunct conjunctiva to further freeze and kill the surrounding cells and remove any kind of remaining metaplastic cells if they are present. This is followed by application of the amniotic membrane graft and a BCL application. However, the downside of the surgery remains formation of symblepharon, limbal stem cell deficiency, development of pannus that needs to be taken care of, and that is what led to the advent of chemotherapy in OSSN. We all know that there are various drugs, that is 5-fluorouracil, mitomycin C, interferon alpha 2B, and of late retinoic acid and anti-VEGF has also been tried. But among all these drugs, mitomycin C and interferon alpha 2B remains the two most commonly used drug in our clinical setup. So comparing these three drugs, 5-FU, MMC, and interferon alpha, interferon alpha 2B remains the most preferred drug, predominantly because of its surface-friendly nature, less toxicity. The success rate for all these three drugs, 5-FU, MMC, and interferon, is similar, but the surface-friendly nature and minimal side effects and less recurrence rate as reported in literature leads to it. The surgeons tend to be in favor of interferon alpha. However, the downside is that the drug is little expensive compared to MMC, hence that needs to be taken care of when you're advising this to your patients. Now, this was a survey done in US over 3 decades. 3 surveys were done with similar questionnaire in 2003, 12, and 22, where a paradigm shift was noted in the management of OSSN. While initially management was with predominantly surgery, it has now shifted to topical chemotherapy or a combination of excision with chemotherapy. So you can see that excision alone was 66% preferred treatment choice, while in the recent study, 54% of the surgeons are preferring only topical chemotherapy for less than 2 mm OSSN. For 2 to 8 mm and more than 8 mm also, a shift from surgery to topical chemotherapy has been noted. So let's see few case scenarios. This was around a 62-year-old female who presented with this appearance. Vision being finger counting close to face, this opacity being present for last 6 months to 1 year. And what you see, there's a diffuse nodal appearance of the conjunctiva, and it's not just involving the conjunctiva around 9 o'clock hours, but also invading the cornea. You can see vascularization happening in the cornea, there is epithelial haze, and the lesion is encroaching on the cornea up to the visual axis. So since in such extensive lesions, the surgery leads to limbal stem cell deficiency, so that's not the preferred treatment now. I started the patient on subconjunctival interferon and topical interferon. After first dose of injection and 4 weeks of chemo, this is how the patient looks like. The lesion regressed from 9 o'clock hours to 6 o'clock hours, and the corneal lesion started to subside. The vision improved to 660, although that's not the primary goal of your therapy, but it did improve as the visual axis started to clear up. At 8 weeks, this is how the patient looks like. In 12 weeks, we kept repeating the injection every 4 weeks, and drops were continued till the lesions resolved. We gave 3 injections and continued the patient on topical therapy. This is how the patient looks like 4 months and At now 8 months, the lesion have completely regressed from the conjunctiva as well as the cornea. The vessels that were present also regressed completely, and the vision improved to 6/12 with refraction. So that is the magic of chemotherapy. This is magic of chemotherapy with topical and subconjunctival therapy. So now this is a second case. This was a patient, 9 clock hours of tumor, not as extensive as the last one, but this patient was also HIV positive. In these patients, again, surgery is not what you want to do. We gave the patient injections, and we gave the patient only topical interferon because we wanted to be least invasive in these patients. And this is how the patient looks like at 3 months. It almost regressed, just a focal nodule left over at the limbus with the presence of a pterygium, and we are continuing the patient on topical chemotherapy interferon. The main challenges with chemotherapy management remains compliance, because when you're doing a chemotherapy, you need to see the patient every 3 to 4 weeks and decide upon the need for injection, or if the patient is not improving, you need to decide for surgery. So a good patient compliance and a good counseling before you opt chemotherapy as an option for your OSSN patient is very crucial. Then second is apprehension. As soon as you tell a patient that you have a tumor in the eye and surgery is one of the option, they will want to be tumor free immediately, that surgery kar do and get me off this. So you need to counsel them that there are non-invasive options and which are equally good to deal with the apprehension of the patient. Patience both at the level of the patient as well as the surgeon is important, because it takes time for the treatment to show its effect. Expense, although people say that interferon is just 700 rupees and it's not as expensive, but it's just not the cost of the drug. The number of visits, the overall duration of the treatment, the number of visits that the patient is going to come to you over 3 months and 6 months, all that adds to the cost of the treatment. So you need to look into it, and adverse effect of the drug. So let's see, this is just a 1 clock hour OSSN, an ideal patient for surgery, but the patient was too apprehensive, wanted to go for surgery, and surgical excision was done. Another patient, just a 2 clock hour of lesion, so we could have given him topical and subconjunctival injections, but chemotherapy was not covered in the insurance, and the patient was not willing to pay anything out of his pocket. So he was under some ECHS, CGHS panel. He said, surgery is covered under insurance, you do a surgery for me. We did a surgery, he became tumor free, but ended up with this complication of symblepharon right at the site where we dissected the tumor. So he saved his money, but ended up in a complication. Now lesions like this who are suspicious, pigmented lesion, impression cytology is not giving you a confirmatory diagnosis. In such cases also, you would like to go for excision and as a part of biopsy to confirm your diagnosis rather than jumping directly to chemotherapy. This is another case scenario, one-eyed patient, other eye lost to glaucoma, this eye having a 0.9 cup. Unconventional therapy is not what you want to do. You will go for gold standard. So we did a surgical excision as well as chemotherapy along with the surgical excision, because one-eyed patients, you do not want to take any chances or delay treatment at any cost. So there are multiple studies that have been done with topical and subconjunctival interferon, and they show good results, all over 90% success rate. Recurrence is less than 5%, and hence, to conclude, chemotherapy is a safe treatment option for OSSN. However, a careful patient selection is something which is necessary. Good compliance and close follow-up is key to success in management of these patients. These are my references. Thank you.
Thank you, Dr. Pranita. You have covered every aspect in this.
Thank you, sir.
Next, Cretan protocol for contact lens. Cross-linking treatment.
Okay, sure. Yes, thank you, sir. So basically, what I'm going to talk to you about is the CXL Plus concept, which is the both Athens and the Cretan protocol to do with cross-linking. We all know that cross-linking has proven itself over now a couple of decades with more than 1,000 published publications, in which we have seen that it is very, very successful to stabilize cornea biomechanically, decrease cornea's deformability, and also, of course, to halt the keratoconus progression. Now, let's look at Swati, who was one of our first patients to undergo cross-linking. You can see that she had actually a progressive keratoconus with a relatively low uncorrected visual acuity of 20/100, a reasonable but lower best corrected visual acuity with the spectacles of 20/60, and a thick cornea of 490 micron. She was contact lens intolerant. This is how she looked like after 5 years. You can see this is the pre-operative and this is the post-operative topography, demonstrating not only that there was a topographic stabilization, but in fact there was a slight improvement. So as doctors, we were very happy, but Swati was not. And that was mainly because she still had low best corrected visual acuity and she was still contact lens intolerant. So then we realized that many of our post-AXL patients do not achieve good functional vision, especially if they cannot tolerate contact lenses, and that's because of the remnant component of irregular astigmatism. To get over this remnant irregular astigmatism, Corneal et al. Devised a two-stage approach in which first they did a cross-linking to stabilize keratoconus, and about 1 year of cross-linking they did a topo-guided treatment to regularize the anterior refractive surface so as to improve functional vision. But in this process, they saw that the haze was higher. They were already removing a cross-link cornea. Therefore, Quinones et al. From our group and again Konolopoulos, both the teams actually published in the same journal, in the same issue, a new approach. Now this is called as the Athens protocol, in which we combine the topography guided PRK along with the cross-linking in the same sitting, so that we can give them the functional vision as well as we can still retain the stability of the cornea with or without the use of mitomycin C. But it is important to note that in this topo-guided PRK, it is not a refractive correction treatment, but it is a therapeutically regularizing module only to improve the functional vision of these patients. So we are not looking at refractive correction. We have to always stay back within the bracket of 40 to 50 microns of ablation and not more than that. Now let us look at this patient who came to us with a topography like this, and then after the Athens protocol, this is the post-operative scan, and you can see a fairly regularized cornea. The patient's vision improved from 6/12 to 6/6 in the post-operative time. Then we went on to do a long-term study in which we compared this PRK CXL, which is the Athens protocol, along with the CXL alone protocol in terms of long-term evaluation to compare visual, refractive, topographic and in vivo confocal microscopic outcomes. And then we could show in these patients that the refractive outcomes as well as the visual outcomes were significantly better with Athens protocol, here gaining 30 letters on logMAR versus only 8 in Athens protocol, and also in terms of the best corrected visual acuity gaining as much as 8.6 letters, as against at only CXL could get only 4 letters gain. It was seen to be a very safe modality of treatment. But now the next question is that many of these patients do not have enough thickness to even do this ablation of 40 microns, which is required in Athens protocol. So what about this moderate keratoconus with even thinner corneas? Therefore, now the next question was that we all know that mechanical removal of corneal epithelium is an essential component of cross-linking, but can we use the epithelial debridement method in itself to improve the visual outcomes of cross-linking methods? We all know that there are a variety of ways in which we remove epithelium in this manner, but there is more insight about this epithelial thickness, which was shown by Dan Reinstein, and we could see that the epithelial pattern in the keratoconus with in this manner is actually not even, but it is thinnest at the apex of the cone. It goes on becoming thicker like annular pattern. So we used this hypothesis in which we actually decided to do a 50 micron PTK. So when we do 50 micron PTK, you are ablating on the thin epithelium, but you are also topping off a bit of underlying stroma so as to give a simulated treatment compared to a topo-guided procedure without using much ablation and without doing a topography guided treatment. So we showcase this by our first paper which we published, in which you can see again the pre and post operative topography, and you could also see the Bowman ablation which has happened at the apex of the cone. Again, we went on to do a long-term study between this new protocol, which was combination of now PTK and CXL, called as the Cretan protocol, versus only the standard resident protocol in a long-term manner. And in this case, we had 38 eyes which were randomized, and we did TPTK by 50 micron, and we could actually showcase that there was a statistically significantly better outcome when we combined TPTK with CXL rather than doing a mechanical epithelial debridement, which was done in CXL alone, with more lines gain, which was seen in the TPTK CXL group as well. So far we have done 4 long-term publications about this, and recently we have showcased that over 5 years of duration, this has shown a very good stable outcome with improved visual analysis. So to conclude, Athens and Cretan protocol both are a good combination of laser along with a therapeutic treatment to improve the functional vision, which is combined with cross-linking to stop the keratoconus from worsening. This can optimize your visual, refractive and topographic outcomes in comparison to CXL alone, and of course in well selected patients. So thank you very much for your kind attention. Thank you.
Thank
Yeah.
You have covered everything in this topic.
Thank you, sir.
It is a recent research.
Thank you, sir.
Thank you.
Thank you.
Acute corneal eye drops management. Munjan Budhiraja.
Good evening, everyone. So I'm presenting the management of acute eye drops in keratoconus and other ectatic disorders. So first of all, what is acute corneal eye drops? It actually occurs following spontaneous rupture of disseminous membrane in the eyes with severe keratoconus. And acute corneal eye drops is the development of marked corneal edema due to a tear in disseminous membrane followed by leakage of aqueous into stroma. The incidence has been reported to vary between 2.4 and 3% in keratoconus, and other corneal ectasias is slightly lesser, including peripheral marginal regeneration to be around 6% and 11.5%. Keratoglobus in 11% and Tyrrhen's marginal is rare. So post-surgical cases have also reported to have eye drops, LASIK-associated keratoconus as well as RKs, and DALK and PKPs also in some patients with keratoconus. So how do they present? The presentations with sudden onset of decrease in vision, photophobia, pain and trivial trauma history. The various risk factors which are associated with increased risk of corneal eye drops include earlier age of onset in keratoconus, eye rubbing, vernal keratoconjunctivitis, atopy, Down syndrome, and amongst all, the rubbing of eye remains to be the most important risk factor. On slit lamp evaluation, we can find marked stromal and epithelial microcystic edema, and there are intrastromal cysts and clefts, and conjunctival hyperemia is also noted in such patients. This corneal edema can be graded according to the extent. Grade 1 is within a circle of 3 mm diameter, grade 2 is between circles of 3 and 5 diameter, grade 3 is larger than a circle of 5 mm diameter. The investigations are based on history and slit lamp findings mostly, and sometimes we require investigation to find out the size and extent of edema as we are moving towards the compression sutures era. The TM tears when we can identify, it helps in formulating our treatment plan, or also to monitor the response to the treatment in such kind of patients. UBM and anterior segment OCT also are very important in the investigations in such patients. So if you look at the flow chart of the patient, acute eye drops, earlier you used to find out that it was conservative management mainly, but as we are slowly moving towards better outcomes, we are resolving to the surgical treatment plans. First is very important is to seal or approximate the disseminate membrane or posterior stromal tear by intracranial air or gas, by compression sutures or plasma injections. Now DSEX also some clinicians and surgeons have tried to do in these kind of patients. Mini DMEC also have worked in a lot of patients, and one is very important, is replace the edematous stroma with pre-disseminated talc. So the management, as I already discussed, conservative approach is with topical lubricants, antibiotics, cycloplegics, hypertonic saline eye drops, and anti-glaucoma medications in some patients may work. Topical steroids have rare role in management of eye drops. Intracameral gas injection with, so if we do conservative approach, the self resolution takes around 2 to 3 months, but intracameral gas injection, it increases the improvement time and it decreases the time taken for the resolution of the edema in such patients. So how do we do the intracameral injection of the gas? So if you see that we are injecting air bubble in the AC in C3F8 bubble, compression sutures also help, and combination of this compression suture as well as intracameral gas injection gives better results. These are the outcomes of different studies in various literature that I have compared and have wrote to have improvement in best corrected visual acuities in such patients. This is the picture of showing compression sutures in these kind of patients. This is one case where a patient reported to have hydrops in PMCD in later stages, but we still went ahead and did compression sutures as well as air bubble injection, and there was a marked improvement in the corneal edema in just day 15. This is a PDEC, the video showing PDEC technique here. So there's a partial thickness definition that has been done, like a DALC we are doing, and then we inject an air bubble, and this is a bevel up needle, not like a bevel down needle, though this is very important to follow to as to avoid any ruptures or any perforations in these kind of patients. So multi-site tangential directed air bubble is very important, and to follow the right plane, and you have to keep on checking whether we are not having any perforations in these kind of patients. So the slow multi-layer dissection is carried out, and here we have to be very careful on the area of the main DM rupture, so that we don't do any frank perforation in these kind of patients. So these are the various results of different techniques. So to conclude, the occurrence of acute corneal hydrops is mostly spontaneous, and it occurs in ectasias besides KZ as well, and it is not just limited to advanced ectasias. And in the event of hydrops, the other eyes is also at the risk of a similar event, so we have to be very, very careful, and we have to prevent the other eye from going into any other hydrops by doing a proper early C3R. So though the initial conservative management is started in all the patients, it prolongs the visual morbidity, and hence we have to go ahead with the surgical management of these kind of patients. So as I already discussed, all the pre-disseminated sutures and compression sutures also, and early DALC in such patients may also work in some conditions. Thank you so much for patient listening.
Thank you, it is a nice talk.
Thank you.
Yes, corneal perforations. Is there
So, is there the next speaker, Nupur Dubey, is present? Our topic is corneal perforation. Is there a hope?
So, whenever we encounter a patient with a corneal perforation, the first question that comes to the mind, if there is a hope. So today we'll discuss various management strategy for corneal perforation along with some of the cases that I have come across. So corneal perforation is a true ophthalmic emergency which, if not treated on time, can lead to devastating complications. These are the various management options which are available. We can choose the best suitable option for our patient depending on the size, location and etiology. We'll discuss each option one by one. So tissue adhesives are more suitable in the perforation which are less than 3 to 4 mm in diameter. We can either use a cyanoacrylate glue or we can use a fibrin glue. Cyanoacrylate glue is preferred in such condition because it is cheaper, stays for a longer time, has bacteriostatic properties and provides more tectonic stability to the globe as compared to a fibrin glue, which is generally used as an adjuvant to Tenon's patch graft or an amniotic membrane graft. So there are various techniques of application which have been described. I prefer to apply with the backside of a Vexel sponge, which helps to apply a very thin layer of glue over the site of perforation. Two very important points that have to be kept in mind is that debridement of adjacent epithelium has to be done and the area of application has to be kept dry throughout the procedure so that the glue holds well. Anterior chamber, whenever required, can be formed with the air or viscoelastics. Especially it is useful in the cases where the aqueous keeps oozing out and we are not able to apply the glue. In such cases, we can just put an air bubble into the AC, which helps to temporarily block the aqueous oozing, and then we can go ahead with the glue application. So this is the patient who came to us with a perforated corneal ulcer, and we did a TA-BCL for the patient. This is how the patient eye looks like after 3 months. Perforation is well healed, and at this stage, we can plan any visual rehabilitation procedure for the patient. This case I have kept to emphasize on the importance of correct technique of application of glue. This patient came to us with a history that TA-BCL was done elsewhere a few days ago. BCL kept falling off and he was complaining of extreme foreign body sensation. So we can see due to excessive glue application, the mound of glue has formed. So we had to take the patient back into the OT. We removed the glue and reapplied a very thin layer of glue, after which the patient was very comfortable. Coming on to the patch grafts, so in peripheral or paracentral small perforations, we can use a lamellar or full thickness corneal patch graft. For example, this patient came to us with a peripheral corneal ulcer with perforation and the flat AC. So we did a corneal patch graft for the patient. Similarly, in this patient also came with a corneal ulcer and a perforation. We did a TA-BCL for the patient, but after 1 week, patient came with a reperforation. We repeated the procedure, but patient was doing well, but after 1 month he came again with a perforation and a flat AC. So eventually we had to do a corneal patch off, and this is how the eye looks after 1 week of doing the surgery. Similarly, this patient, a very young lady, came to us with a peripheral perforation with a 7 to 10 days history of blunt trauma and a iris prolapse. So we upsized the iris and did a peripheral patch graft, and she did very well in the post-op period. This was a very unusual case. A 65-year-old lady came to us with a history that she was taken up for cataract surgery, and after administration of peribulbar block, when she was taken to the OT, the surgery was cancelled and the eye was patched, and she was referred urgently to a cornea surgeon. She came to us after 3 days when we noted superior corneal thinning and multiple site perforation. This is how the other eye looked like. So we had to eventually perform a lamellar crescentic patch draw for the patient, and she did well. So in the cases of peripheral larger perforation which cannot be managed with glue alone, we can use a multi-layered AMG along with overlay sutures and the fibrin glue. So it's especially useful in the cases which are associated with the aqueous deficiency disorder, for example, rheumatoid arthritis. But AMG, what it does, it gets integrated into the healing stroma and provides tectonic stability to the globe. But it cannot be used in the cases of infection. Similarly, Tenon patch graft is also very useful in the cases where scarcity of the corneal tissue is a problem. It is also indicated in the perforations which are secondary to an underlying autoimmune etiology and not infections. As it is an autologous tissue, there is no risk of tissue rejection or need for long-term corticosteroid therapy. In the cases of central large perforated corneal ulcer, therapeutic keratoplasty is the only option. But there are so many challenges that we face during TKP in a perforated cornea. So first, because of excessive hypotony, definition is very difficult. Flaringa ring is very useful in such cases. Even after that, chances of injury to the iris lens complex during definition are very high. So AC always has to be formed before trephination with the viscoelastics, and in fact we can just make a superficial mark with the trephine, and then hose button can be excised with the help of a side port blade and a Corneal scissors. So this is a patient who came to us with a central large corneal perforation, and we did a TKP for the patient. Within a few months, patient developed a cataract as well, intumescent cataract, so we had to perform a cataract surgery as well for the patient. This lady came to us for manual SICS we performed, and the post-op course was uneventful. After 6 weeks of surgery, she came to us like that. When we reviewed the old record, there was a scar which was mentioned in her records, which was missed, and so we suspected a recurrence of the viral keratitis. We initially tried a glue BCL for the patient, but didn't work, so we eventually had to perform a eccentric large draft for the patient, and she did very well. This is a very young guy who presented to us with a fungal perforated corneal ulcer. We did a TKP. This is how the eye looks like on POD3. Unfortunately, the patient developed a graft failure, but we were eventually able to rehabilitate the patient as we performed a second surgical intervention, phakic DSEC, and patient was able to get 6/18 vision after 4 months of surgery. So to conclude, yes, there is a hope provided timely intervention is done in such cases. Primary aim should always be to restore the integrity of the globe and control of any infection if it is present. Secondary surgical intervention can be done once inflammation is well under control. Whatever we do, good patients counseling regarding long-term follow-up and need of multiple surgical interventions is the key to success. Thank you.
Thank you, Dr. Nopar. You have covered everything in this topic, and it is a common problem, corneal perforations in all our OPs, general OPs. We see most of the cases in our OPs.
Vanati ma'am is not there. So the next talk is from Vanati ma'am. I think she is not there.
Close the session.
So we can close the session with that. So